And joining us in the studio for this week's Your Health segment is Dr. Sanjay Rajagopalan, professor of medicine at the University of Maryland School of Medicine and chief of cardiovascular medicine at the University of Maryland Medical Center. Doctor, thanks for being with us.
Thanks for having me on the show, Jeff.
We hear all of these recommendations about preventing heart disease, protecting our heart health, largely focused on cholesterol and blood pressure, correct?
That's correct. So the new guidelines for blood pressure management and lipid management came out late last year after a very long awaited 4 to 5 years when the recommendations were initially launched. The blood pressure guidelines go back nearly 10 years ago when the JNC7 guidelines were launched, and this is the next iteration of the blood pressure guidelines, which were eagerly awaited for many years, and so was the case for the lipid guidelines as well.
When you say lipid, that means cholesterol.
Blood cholesterol management, that's correct.
How has it changed?
Well, there's some big changes, and with regard to the hypertension guidelines, one of the interesting things was they somewhat seemed to relax the blood pressure levels, especially for Americans above the age of 60. So the previous guidelines in JNC7, the previous iteration, said most people need to have their blood pressures below 140 millimeters of mercury systolic, which is a top blood pressure,
line, right,
and then 90 millimeters of mercury, which is a bottom blood pressure, or diastolic. And for certain risk groups, particularly if you're a diabetic or if you had kidney disease, they even recommended much more stringent control of your blood pressures. But these guidelines were a shift in that sense, where they said, well, they relaxed the guidelines because they were really focusing on what we have evidence for. So this guideline was a shift in the sense that they addressed only areas or questions for which there was evidence. And they said, okay, well, if you're below 60, then it's reasonable to have your blood pressures below 140/90. However, if you happen to be above 60, then it's okay to have your blood pressures less than 150/90. So they relaxed the guidelines a little bit, and that's gotten a lot of people a little bit concerned.
So does that mean that fewer people have to be on blood pressure adjusting medications?
Well, yes. The implications of this directly are that perhaps, for a large segment of the patient population, particularly above the age of 60, it's okay, at least that's what the guidelines say, to have blood pressures less than 140/90. And this has created a lot of controversy. And a lot of people, including myself, feel that perhaps a unifying number of less than 140/90 has worked very well. We worked for almost a decade to get the message out to the public to say to get your blood pressures controlled, and the ease of one single number has really hit home in terms of people understanding what these levels are. Now to go back and say,
we're going to go change the number.
Right. It's been very confusing for the public.
And I suppose we should emphasize, and correct me if I'm wrong, but these aren't magic numbers. Somebody with a blood pressure, a top line of 139 may not have that different a future than somebody with 142, for example.
That's an excellent point. So these are, after all, numbers. And ultimately, what these risk factors are really telling you is to really focus on the risk of an individual. And that really is also another shift in the guidelines, particularly the lipid or the cholesterol guidelines have really seen a sea change in terms of focusing away from numbers, but rather focusing on the risk of the individual. In other words, what do these risk factors of high blood pressure, high cholesterol, diabetes really tell you? They tell you about risk of an individual.
Because people with great blood pressure and great lipids, still occasionally somebody has a heart attack.
That's right. So it's all about controlling these risk factors, but on the other hand, it doesn't certainly preclude or doesn't eliminate risk. After all, it's some sort of probability game that you're playing, and you can play the game to your odds by getting your risk factors under control. But what we find in our practice, Jeff, is quite honestly, patients relate much better to the concept of risk rather than numbers.
Interesting.
If you tell them, listen, you're at risk, and your risk of having an event like a heart attack or a stroke is this %, that really hits home, rather than telling them, well, let's get your blood pressure controlled to a number, which you might, very easily forget. And it's hard enough keeping track of all these new guidelines, which oftentimes go back and change what they said a few years ago.
Well, let's dig into how you reduce somebody's risk. But first, a phone call. This is Anthony in York, Pennsylvania. Anthony, thanks for the call. Go ahead.
Thank you very much for taking my call.
You bet.
Question for the doctor. I work out three or four times a day, or 3 or 4 times a week.
Wow. Okay.
And 3 or 4 times a week here at my home. Not very vigorous, and then I'm also very active at my job, walking. I manage property, but I'm also taking a testosterone supplement, herbal blend. And by the way, I'm 60 years old, and I have 6 stents in my heart. Now, I just read recently in Time magazine about these herbal blends of testosterone boosters are bad for the heart and give you a greater risk of heart attack. Is this anything I should be concerned about?
So, Anthony, this wasn't prescribed by anybody. You're just taking it.
Well, no, my family physician said I could take it. He read the ingredients, and he suggested I take it just as a supplement.
Great phone call. Thank you. We'll get you an answer.
So, Anthony, can I ask you a question?
Too late.
Oh, too late. Okay. So let me just give you some broad recommendations. In general, you are correct. If you're taking supplemental testosterone, which is recommended by a physician, there is an association between testosterone, getting supplements, especially if they're above a certain level, and risk for coronary artery disease. But in every individual, it's sort of a decision based on risk and benefit. There's obviously situations where testosterone supplementation might be beneficial for a number of other added supplemental health benefits. So just like in other cases, one has to look at the risk versus benefit.
Joseph in Baltimore City. Joseph, thanks for the call. Go ahead.
Hey, how you doing?
Good. How are you?
Okay. I see on the program some like the other day about drinking watermelon juice or whatever was on. And every time I go to the doctor, my pressure is 170. Thank you.
Say that again, Joseph.
It's a drink that they got out there. They call it watermelon drink.
Watermelon drink, but your blood pressure is still at 170. Are you dealing with that in another way?
Yeah, every time I go to the doctor, I come, my pressure is up. It's over 170.
Okay. We'll get you an answer. Thank you, sir.
All right, thank you.
Well, Joseph, thanks for your question. That blood pressure is concerning to me, so you really have to pay attention to that, and you might need to be on medication. So I would make sure that you see your physician, get a better handle on your blood pressures, particularly get your blood pressures at home with a blood pressure instrument that you can purchase from a pharmacy store, and keep tabs of your blood pressures and take it to your doctor's office. And you really need to address that blood pressure. If it's elevated chronically, this might pose a risk to your heart.
What are the methods, broadly speaking, that somebody could bring down a blood pressure number like that? There's medication, and then there's maybe diet, exercise, and other things you can do.
So if the top number, the systolic blood pressure, is persistently about 170 millimeters of mercury, you need to be on medications. So that's
not borderline.
That's not borderline.
Right.
That's absolute black and white. There's no denying it, and you need to be in medications. And usually with that kind of pressure, you need to be on 2 or more medications. Now, if you had pre-hypertension, which is usually blood pressures between 130 or 140, now the current guidelines don't make that distinction, but the Europeans do, the previous iteration of the guidelines do, or if you happen to have borderline blood pressure, there might be a role, again, talking to your physician about alternative non-pharmacologic approaches. Exercise is one of them. Diet is a big, big part of reducing blood pressure. Lowering your salt intake is huge to do with reducing your blood pressure. Aerobic exercise training, for instance. Deep breathing exercises. There are also devices that you can use to control with resistive exercise training, like passive squeezing with devices or deep breathing exercises.
Really affects blood pressure?
Yes, it can lower your blood pressure as much as 5 to 7 millimeters of mercury. So it means a difference between being hypertensive and going to a normotensive range, or having systolic blood pressure less than 140 millimeters of mercury.
Let's get into the cholesterol side. You said the recommendations there have changed as well.
Yeah. So the big changes in the most recent iteration of the lipid guidelines is a focus on risk. So rather than looking at cholesterol numbers, the focus is on risk, because there's an overwhelming body of evidence that seems to suggest that, number one, patients relate better to risk when presented to them. And secondly, numbers always change, as you have pointed out earlier on. And if you identify patients at risk, you can target them for appropriate treatment. It creates awareness and involvement on the patient's part. The second big change is the focus on statin therapy. Statins are a group of drugs that lower cholesterol. They've been around for more than 2 decades. Highly effective drugs in our war against coronary disease. And these drugs can be recommended if you belong to 4 different certain category of patients, and those are people at high risk, people who are diabetic, people who have LDL cholesterols of more than 190 milligrams per deciliter. These are high-risk groups that need to be on statin therapy.
Let's talk to George in Anne Arundel County. George, thank you for calling. Go ahead.
Thank you.
Thank you.
I would like to know how all of these brilliant physicians and PhDs in the area came up with the theory that we should add the good cholesterol, the HDL, to the bad cholesterol, the LDL, and come up with a number that is used in any way whatsoever. How can you add a good thing and a bad thing together and say that the resulting number has any significance?
Great question, George. Thank you. What's the science there?
That's a great question. I think the body of evidence is mainly from large population-based studies, or what we call epidemiology, to make these associations. So there are clearly risk factors that have a positive association or carry a connotation of increased risk, and there are others that carry an association with negative risk. And we also know that cholesterol is extraordinarily complex. It is obviously carried in different compartments, and there are lipoproteins or proteins that shuttle cholesterol. And the cholesterol content, and this is the way the studies were done originally, where they identified a negative association or a reduction in risk with high levels of HDL cholesterol. And it was so strong, even after they adjusted for various covariates, as they call it, and this negative risk connotation persisted. So they built this into the risk model. So they put together things like age, which happens to be a big risk determinant, LDL cholesterol or bad cholesterol, HDL cholesterol or good cholesterol, to come up with a risk estimate. But you're right. I mean, obviously the body is complex. There are many different things that work in opposing ways, right? And that's how this is all based on.
I just have half a minute. What do you want our viewers to take away from this? At a certain age, 50 up, 40 up, you need to get what checked?
Right. So the United States Preventive Task Force makes broad recommendations on what age groups you need to have your lipids, your blood pressure checked. In general, I tell my patients, if you happen to be at risk, if you have a history of premature cardiac or stroke disease in your family, it's always a good opportunity to get your lipids checked, to get your blood pressures checked. If you have no such risk factors, the U.S. Preventive Task Force recommends that if you're a man and you're older than 35, you can get your lipid profile checked. Blood pressures at any age.
Doctor, we're going to have to leave it there, but we do appreciate the visit. Thank you for being with us.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.